Welcome. Hello, everyone. My name is Colleen Daniels. I'm the Deputy Director and Public Health Lead here at Harm Reduction International. We're so happy you could join us today. We are here together with CHI, the Clinton Health Access Initiative, as well as collaboration with the World Health Organization. What we're going to do today is really try and talk about some of the issues around integrating viral hepatitis, particularly hepatitis C, into harm reduction services. As many of you might know, viral hepatitis C and B affects more than 325 million people worldwide, with about 90% of infections actually concentrated in low and middle income countries. And this disease leads to significant liver damage, liver cancer, and liver failure. And 80% of people living with hepatitis actually lack prevention, testing, and treatment services. And as a result, this causes about 1.4 million deaths per year. And HCV is actually curable in more than 95% of patients with direct-acting antivirals. Yet only 7% of those infected receive treatment. And in low and middle income countries, only a fraction of those who actually in need receive even a vaccination as infants or treatment as adults. So as you might know, the World Health Assembly endorsed the landmark global health sector strategy on viral hepatitis from 2016 to 2021. And 194 countries actually committed to eliminating viral hepatitis by 2030. But we are very far from reaching those goals, unfortunately. And without good, with strong political will, multi-stakeholder collaboration and advocacy, we will not reach these targets. And we will miss our biggest opportunity to seize the momentum and eliminate this killer. And one of the biggest groups of people who are actually missed in prevention, diagnosis, and treatment are people who use drugs. And harm reduction interventions are desperately needed. So globally, more than half of all people who inject drugs are estimated to carry hepatitis C antibodies, meaning that they have been infected with hepatitis C virus at some point in their lifetimes. And the World Health Organization, and you'll hear in a few minutes, recommends testing and treatment for hepatitis C for people who inject drugs. And harm reduction interventions, such as needle and syringe programs and the distribution of safer smoking equipment, are both means of reducing the sharing of equipment, which could lead to viral hepatitis transmission. And opioid agonist therapy and drug consumption rooms also reduced higher risk injection practices associated with viral hepatitis. So what we're here to do today, and we have amazing speakers who are going to share with you, are some of the opportunities for us to actually be able to integrate viral hepatitis and harm reduction programs. We know that people who use drugs, and most people around the world, to be frank, need services that are integrated. We can't continue to have separate services where someone living with HIV goes to an HIV clinic for their medicines or a TB clinic to address their tuberculosis. We need to be able to have a person-centered approach that is based in evidence and human rights. And integration is one of the most cost-effective ways of approaching that as well. So I'm very happy to be able to introduce this morning our first speaker, Dr. Antons Mozalevskis. Antons, how can I even butcher your name this early in the morning? It's not good. He's a public health expert with a background in family medicine, infectious diseases epidemiology, and community activism. And from 2015 to 2022, he served as the regional advisor for viral hepatitis at WHO, the office in Europe. Since 2022, he has been the technical officer for key populations at the Global HIV, Viral Hepatitis, and STIs program at WHO in Geneva. Antons, welcome. Over to you.
Thanks, Colleen. While the slides are getting up, I would like to thank the organizers for this excellent event, and very timely and very important. And I don't know, excuse me, can you? Yeah, exactly. And thanks, Colleen. You actually already did a good job setting the scene and stating about the problem. But maybe just to repeat, So hepatitis B and C are major public health threat, comparable to HIV or tuberculosis. So maybe looking at the burden, it's could be even a bigger problem, and particularly for people who inject drugs. Can you press the next slide? No, I can see the kind of the presenter's mode, and anyways, please press the next slide. I will go quickly, not to spend too much time. So here you can see that according to the latest WHO report, hepatitis B affects almost 300 million people, and globally the biggest burden is in the countries of East and Southern Asia, and also in Sub-Saharan Africa. And hepatitis C, the current estimate is just below 60 million people living with chronic hepatitis C infection, and this burden is more equally distributed, but some regions like European region or Eastern Mediterranean regions, they have estimated to have a higher incidence, and particularly people who inject drugs are at higher risk and also have the higher burden. Next slide, please.
Sorry, just Antons, I'm just going to interrupt. Temitope, can you please change the view so that it is showing the slides and not the presenter view? Thank you so much.
I think sometimes it's work when you kind of duplicate the screen if you have two screens. So, anyways, as you could see on the previous slide, yeah, maybe that's better if you don't manage to. Yeah, as Colleen already mentioned, every second person who injects drugs is living with hepatitis C. But these estimates are very different from country to country, and especially we know when people who inject drugs, they are also living with HIV. The risk of having hepatitis C is much higher, and what we could see, for example, in Eastern Europe, so in regions where HIV is affecting people who inject drugs, the hepatitis C prevalence is close to 90%. So it's really a big problem for people who inject drugs. And also hepatitis B actually can have a higher burden in people who inject drugs with large regional variations. So this kind of explains partly also why integrated approach is so important. Next slide. So last year, WHO has updated the key population guidelines, and for the first time, we made a decision, or yeah, basically, it was very logical to integrate HIV, viral hepatitis, and STI. So we are trying to suggest the countries to address all those three infections in key populations in an integrated, person-centered way. So in these new guidelines, we recommend an updated package of interventions for HIV, hepatitis, and STI prevention, diagnosis, and treatment. You can see it on the right side of the slide. And these interventions are prioritized. So those are enabling interventions that address structural barriers, such as removing punitive laws, reducing stigma and discrimination, and empowering communities. And interventions for health impact, which include prevention, diagnosis, and treatment. And you can see that all those interventions are integrated, addressing both HIV and hepatitis, and ideally in the same settings. Can you move to the next slide? So in this new key population guidelines, we have new hepatitis C related recommendations, which are particularly relevant for people who inject drugs, and these relate to retesting for hepatitis C reinfection for the people among the people who had hepatitis C infection, who were treated successfully or cleared spontaneously, if they are at ongoing risk. So if they're still active injectors, we recommend to offer testing for viremia every 3 to 6 months. Of course, when in the settings where it's relevant, but we have to work on making these interventions available and accessible. And the second one is on treatment of recent infections. So we used to call it acute hepatitis C, but now it's more called a recent hepatitis C infection. And people with ongoing risk, we recommend to start treatment immediately, also to prevent onward transmission. Next slide. Also, next year, last year, we also updated our hepatitis C recommendations, like general hepatitis C recommendations, but we made very clear that decentralization and integration is very important approach, particularly in harm reduction settings, in prisons and in OAT settings. That's proved to be both effective and cost-effective. So you can see, I will not go into details for the sake of time, but providing hepatitis C diagnosis and treatment in harm reduction settings is very, it improves linkage to care, it improves uptake of services, and eventually it's very good, let's say. Next slide. We have done, or we have seen some evidence for the importance of integration of hepatitis C treatment, harm reduction, like syringe provision and OAT, which altogether as a package is the most effective way how to reduce the incidence by the results of modeling. And if we want to eliminate hepatitis C, as we have set in our global goals, we have to provide all those three interventions at the same time. And the last slide, so the key messages, I'd like to say that first of all, hepatitis elimination won't be possible without prioritizing people who inject drugs. Also combining all three interventions such as NSP, OAT, and treatment will reduce hepatitis C in people who inject drugs by 90%, and decentralization and integration of hepatitis C services can increase uptake, linkage to care, and overall success of hepatitis C treatment programs. So that's looking from the hepatitis C perspective, but there is increasing evidence that offering integrated services improves acceptability, attractiveness of the services, and eventually can also benefit the HIV program and other health programs. So I'm sure we will see from the presentations today at this webinar that this concept of integration has really been successful in different settings. With this, I'd like to thank you for the attention, and I stay here for any of the questions. Thank you. Over.
Thank you so much, Antons, for giving us that overview. We really appreciate it. If you do have questions, please put them into the chat, into the Q&A. You'll see that's available, and we will try and answer as many questions as we go through. Our next speaker is Aditya Taslim, who may be having a problem joining us. And so I might actually, Susie, I might go to you instead while we're waiting for Aditya's technical issues to be addressed. So Susie McLean is the Senior Advisor on HIV prevention at the Global Fund and leads Global Fund's efforts to ensure that resources for HIV prevention are focused on the populations with the greatest HIV prevention needs and on interventions that are most likely to have impact. She has worked in harm reduction, financing, and large-scale service delivery models for many years. And so we would like to introduce, welcome, Susie. Thank you.
Thanks to you, and hello, hello, all colleagues. It's great to have this opportunity to join this discussion. My thanks to Harm Reduction International, Colleen. I think it's a fantastic idea to bring us all together to discuss these issues, and it's fantastic to see a lot of colleagues from countries where the Global Fund is investing in harm reduction. So a special hello to Global Fund recipients, as we say. It's also great to follow Antons and the WHO message on integrating hepatitis into harm reduction programs, because I wanted to begin by just a slight little aside, I decided against using slides. The speakers have been given, a short period of time, and I really just wanted to make 3 messages. And I thought it might be best to do so without slides. But the first message is that the Global Fund has updated its funding guidelines on its modules. It was part of our modular framework to address 2 important factors. And the first one, Antons just spoke about. So the first kind of driver of the updating of our guidelines in this area was the updated WHO guidelines on HIV, hepatitis, and STIs. So they're the technical agency that the Global Fund responds to. And so as the WHO updates its guidelines, it's incumbent on us in the Global Fund to respond accordingly. And so in that, Anton's already referred to this, but in that WHO update, there's this driving principle, which I think is interesting and relevant to today's discussion, which is the principle of organizing services around people's needs rather than around single diseases. That's a pretty big consideration for us at the Global Fund, who have a responsibility to invest in 3 single diseases, but I'm hoping that people are seeing this evolving imperative around people-centered services, more sustainable services, and kind of a wider set of investment choices and opportunities in order to address the 3 diseases. So this is a classic example of that, really. The second thing that's driving our and linked consideration that's driving our changes in our funding guidelines in 2022 is sustainability concerns and this overall interest that's expressed in our strategy for stronger and more sustainable health and community services. And so therefore services that offer more health impact are more likely to be cost effective, are more likely to have greater health impact, and are more likely to be used and to be sustained. So our interest in expanding the kind of health impacts from our HIV harm reduction investment, very clear Global Fund priority. This is a perfect example. Okay, my second point is, as many of you know, the Global Fund is the largest or one of the largest international donors for harm reduction programs. It's an area of our investment that we feel very proud of and very protective to ensure that it grows and develops. We note that an increasing number of countries are applying to the Global Fund for resources to either establish or expand harm reduction, and we really welcome this. And in the context of us being a prominent donor for harm reduction, and in the pertinent to today's conversation about integrating hepatitis C services, it's important to state, and many of you will already know this, that the Global Fund has funded hepatitis C prevention for many years, many years. So, those of us that are involved in service delivery know that when you're, for example, offering HIV prevention programs to drug users, we're also offering hepatitis C programs, prevention programs. And in many cases, many Global Fund funded programs include hepatitis C testing, for example. But hepatitis C treatment is the development that I wanted to refer to today. And it's about the change in policy from last year for the current cycle. And this change in policy is expressed in our comorbidities, co-infections policy that's an appendix of the Global Fund's HIV information note. I can clarify these links and these documents in the chat once I finish speaking, just so everybody can see that. The other area where people can see these changes is in our modular framework, both resources available easily online. And so, but this change in policy to be more inclusive of hepatitis C treatment accompanies a whole other set of policy changes that are about this direction of travel. So, for example, much more explicit commitment to funding STI diagnosis and treatment, hepatitis B as well as hepatitis C, more interest in funding more in the HIV advanced disease space. So just important to recognize that this hepatitis C treatment change that I'll discuss today is in the context of a much wider set of guidance on a wider set of health concerns. And so previously, as many of you will know, the policy had this, the hepatitis C treatment policy had this constraint, which was around people living with HIV. And we knew that that was a real problem for many people providing services to people who use drugs, where they're only able to provide life-saving hepatitis C treatment to people who are living with HIV and not to people who are HIV negative. So we knew that that was a problem, and we knew that that was an inefficiency, and we knew that it sets up a kind of a access and rights problem. So we set about to change that. So it's quite a modest change, but I think this audience here in this webinar will recognize that in our world of harm reduction, that it's quite a significant development. And just to be clear, the development is that we no longer have that constraint around living with HIV. So all people who are in need of hepatitis C treatment that are using harm reduction services, a Global Fund, the hepatitis C treatment is eligible in Global Fund terms. What we do have, though, to accompany that is another kind of constraint, because what we don't have is resources to fund national hepatitis C treatment programs for everybody who needs hepatitis C treatment. The concept is, or the constraint is, it's around the harm reduction service delivery platform. So where we're already investing in harm reduction services, HIV prevention, HIV treatment, OST, overdose, etc., those harm reduction service delivery platforms, through that, we're able to fund hepatitis C treatment. So really the intention is for the investment to be targeted towards key populations, in particular, people who use drugs, not whole general populations. It's a kind of a key population oriented focus. And yeah, I think all of us can see that there are great opportunities to prevent much more disease and to prevent many more unnecessary deaths. And it's worth noting too that another big driver for our ability to increase the flexibility around our funding guidelines around hepatitis C treatment was the dramatic decreases in the cost of hepatitis C treatment. Been a very powerful driver for our ability to fund more in this space. Yeah, so that's my second point, just to be clear about the opportunity, the Global Fund's interest in funding more in this space. So my third point, and then I'll wrap up, Colleen, is about what's happening now. So as many of you know, Grant Cycle 7 is underway, and many countries have submitted their funding requests, and some of them have been finalised and approved. But that process of finalising and approving is underway in many, many countries. And so we are looking a lot at the HIV, the planned HIV prevention investments, and in that we're looking a lot at the harm reduction investments, and including the hepatitis C treatment investments. We can't give any big numbers yet. We hope to, as soon as all of the grants are finalised and agreed and approved by the GAC, the Global Funds Grant Approvals Committee. But at the moment, while grant making is underway, we just don't have the final numbers. But just note that we intend to share more information about these investments as the grants are finalised. But I can give you a couple of indicative signals from what we can see so far, just to give you a bit of a flavour about the appetite or the uptake, I suppose, in response to the opportunity. And so we're seeing at the moment, and importantly too, we're in window 3, Grant Cycle 7, window 3 funding requests have just come in. So the numbers that I refer to here don't refer to window 3. And then there's a window 4 also early next year. So the complete picture for grant cycle 7 is actually not possible until kind of Q1 next year. But windows 1 and 2 were the big ones, are the big ones. So the main trends are visible in windows 1 and 2. And these numbers that I give you now from windows 1 and 2. So we can see that 24 countries have included hepatitis C test and or treat in their funding requests. And we can see 12 countries at the moment that have included hepatitis C treatment in their funding requests. So I'm not sure what to say about that number, 12 countries. We can discuss it. But yeah, I suppose from a personal perspective, this is not a corporate position. This is me speaking personally as someone who's interested in expanding access to hepatitis C treatment. I'd hope for a longer list. But anyway, let's debate that at the moment. At the moment, it looks like there's 12 countries that have signaled to the Global Fund their interest in hepatitis C treatment. So as mentioned, the analysis continues. On models of integration, we haven't done any deeper dive yet, and we'll do a bit more later. But this is why I was really happy that HRI hosted this debate. I feel like at the Global Fund, we've got lots to learn from recipient countries about your models for integration. We want to dig a bit deeper and analyze this a bit more, but it will really be about just watching what you are doing. And then in that deeper dive that we'll do possibly next year, we'll be able to understand a little bit more about what are the costs that accompany integration of Hep C treatment into harm reduction, and then what are some of the effects, what are some of the benefits and the results that accompany that. But at the moment, that's not known. So once again, fantastic opportunity to have a discussion on these themes. And yeah, from the Global Fund perspective, we've got a lot to learn from recipient countries about models for integration. So back to you, Colleen, and I'll stay here listening intently for the rest of the webinar, and happy to comment and answer questions a bit later on if appropriate.
Thank you so much, Susie. And I think, yeah, when you hear 12 countries, my heart just sort of stopped and everything in my guts dropped, because this was such an opportunity for countries to be able to put it into this next 3-year cycle. So I'm hoping that maybe with this webinar and other work that we're able to increase this in grant cycle 8. I guess one thing is that, as we now move into grant making for these 12 countries, I do hope that hepatitis B and C is prioritized during grant making, because we do know that sometimes it gets dropped. But we would love to hear more from you, and people have questions, please do put them in the chat. Our next speaker is Navya Sharma, who is based in New Delhi, India. She works with the global markets team at CHAI, and as part of her work, she supports the CHAI's hepatitis program in market shaping for hepatitis commodities. Please, she has been working there for about 2 years now, I think, Navya. Thank you, welcome.
Thanks, Colleen. Hi, everyone. It's a pleasure to be here. So as the title of my presentation suggests, I'll be speaking to you about market intelligence on hepatitis commodities. Now, to preface some of the key topics I will be presenting to you, I'd like to note that one of the key factors to successful integration of viral hepatitis and harm reduction services is commodity availability and pricing. Pricing specifically directly affects the ability of public programs, firstly, to optimize their budgets, and secondly, to increase coverage through scale-up of services. Now, in this presentation, I'll be covering pricing of hepatitis treatment commodities, specifically CHAI's recent ceiling price agreements to improve affordable access to these commodities, and our latest market intelligence work on harm reduction. Now, CHAI routinely collects pricing and other market intelligence data as part of our market shaping efforts. And over the years, we've tracked and analyzed a bunch of this data, and we've observed that there is significant price variability for hepatitis treatment commodities across LMICs. While the global hepatitis community definitely, and as my previous speakers have noted, has made significant progress in bringing down prices, you can see on the graphs to the left of the slide that these successes are definitely unevenly distributed. For instance, you'll observe that some public programs are able to access quality assured direct-acting antivirals to treat HCV patient at about $60, and while some other public programs pay close to $1,000 for the same treatment cost. Similarly, for HPV treatment drug tenofovir or TDF, you can see a similar large price variation. Now, globally, about 80% of people with hepatitis lack access to prevention, testing, and treatment services, and such price disparities play a big role in that. Next slide, please. In a step to combat this price variability, in May 2023, CHAI and the Hepatitis Fund signed a ceiling price agreement with 2 generic manufacturers of hepatitis drugs. Now, these agreements are part of a concerted effort by partners to increase access to and significantly reduce the cost of treatment to LMICs and enable scale-up of hepatitis programs to meet growing demand, ultimately working towards eliminating hepatitis. Public programs will be able to access a 12-week course of HCV treatment drugs. So first, is someone coming in?
No, Dr. Ganiyu, could you please mute?
Okay. Oh.
My apologies. I'll continue. So I was just mentioning that public programs through these pricing agreements will be able to access a 12-week course of HCV treatment drugs. So fosfuvir and declatosvir at about $60 ex-works price. And there are also similar agreements for diagnostic commodities. And together, the cost of HCV commodities via these agreements comes to about $80 per patient. These agreements also provide public programs access to HPV treatment drug TDF at about $29 ex-works for a year-long course. I would urge participants to visit our website for more information on these agreements, and you're more than welcome to write to us, and we'll happily help you kind of navigate these agreements. I'll also, after the presentation, I'll just send some links in the chat for the participants to kind of access the relevant pages on our website. Next slide, please. Now, as I'd mentioned earlier, CHAI regularly tracks market intelligence information for hepatitis commodities, which informs our market shaping efforts, like the pricing agreements I just spoke to you about. We also publish this market intelligence in the form of market reports for the consumption of a variety of stakeholders. These reports are aimed at enabling market transparency and providing actionable market intelligence to relevant stakeholders. To date, we have published about 4 of these reports on HCV and HPV markets and are currently working on the 5th edition of the market report, which is due to be published in early November this year. Can we move to the next slide, please? The upcoming market report will have 2 major sections covering key insights into HCV treatment and diagnostic commodities. For the first time, this report will also include market insights into some key commodities used in harm reduction services. Now, I think we can all agree that injecting drug use is definitely a key factor in HCV transmission, and globally, approximately 43% of new HCV infections are attributed to it. WHO, as Antons mentioned at the beginning of the webinar, recommends providing people who inject drugs with access to comprehensive services that include harm reduction. Now, while this approach is definitely crucial to reducing HCV transmission and moving towards elimination, we have noted that the on-ground reality is that there exist numerous barriers that hinder access to harm reduction commodities and service expansion. These barriers, especially the lack of market transparency, prevents public programs from making informed decisions about selecting, procuring, and introducing relevant commodities in harm reduction programs. CHAI's hepatitis team, as part of our market shaping efforts, has conducted an initial scoping to understand the market landscape of harm reduction commodities. Now, as part of the report, we'll explore 3 sort of major groups of commodities. We'll be exploring and sort of providing you key insights about OAMT commodities, namely methadone and buprenorphine, overdose prevention commodities, naloxone, and needles and syringes that are used across harm reduction programs. Now, we intend to publish some key insights and trends about consumption of OAMT commodities in LMICs versus HICs, an overview of the supply landscape of OAMT commodities, key trends in needles and syringes market, specifically focusing on the demand side perspective, and also some key pricing information that we've been able to collect for various commodities across different LMICs in various harm reduction settings. Now, we hope that these preliminary insights will be a first step in opening up the conversation and ultimately addressing market and commodity-related barriers in harm reduction. To kind of conclude and end my presentation, I'd like to note that the report is currently a work in progress, and we will be presenting more detailed information, insights, and data closer to the launch of the report in November. Till then, you can stay updated by monitoring our social media channels for information regarding the report's release date and, other sort of conversations that we'll be scheduling over the coming months. Thank you so much. Over to you, Colleen.
Thank you so much for that. And we're looking forward to actually seeing the final report. I think it's interesting now, and as Susie also mentioned, this decrease in price is enabling people to be able to actually develop and introduce services. I think we also need to start thinking about, as a global community, what can we do together to actually drive prices down further? So how can we utilize, maybe global fund procurement processes to do advanced purchase, or PEPFAR processes to do advanced purchase for countries or group countries together? That might be another option. So thank you so much. Our next session, we are going to be looking at we're going to try and showcase some key models of successful integration of viral hepatitis and harm reduction services. And our next speaker is, our first speaker on this panel, actually. Yolaan, if you'd like to turn on your camera. Ms. Yolaan Andrews is the Key Populations Program Manager for Networking HIV and AIDS Community of Southern Africa, called NACOSA. They're also the principal recipient for the Global Fund program for people who use drugs. And she actually leads the People Who Inject Drugs program, which is being implemented in 8 cities. So it's my pleasure to welcome my fellow South African, Yolaan. Over to you. Thank you.
Thanks so much, Colleen. And it obviously is a pleasure to represent the work that Global Fund is doing in South Africa. As everyone can imagine, it is especially important considering the number of people who inject drugs, as well as smoking heroin, that are at risk of hepatitis B and hepatitis C. So if we can move to the first slide, if you don't mind. Timmy? Apologies, Colleen. I'm just waiting for the slide to show.
No problem. Maybe you get started. It looks like we might be having a technical issue.
There we go. It seems good there. So, okay, so just to start off, and we can go into the second slide if you don't mind, Timmy. So viral hepatitis in South Africa, as I mentioned before, is a significant problem. South Africa being one of the highest HPV prevalence globally, and then also around key populations, specifically sex workers, MSM, people who inject drugs, with 60% of the population having hepatitis B and hepatitis C co-infections in public health clinics, with really any treatment available or provided. So NACOSA, as the Global Fund principal recipient, has been, working on harm reduction programs in South Africa. And we have seen that, working with PWORD, that there's an incredibly high number of hepatitis C positives. This is graph that you're seeing currently from the Bristol-Myers study done in 2017-2018, show that, in Durban, Cape Town, and Pretoria, with the current harm reduction services, that there was a size estimation of those with hepatitis B, hepatitis C, and those with comorbidities. And this really advocates, why we need to be ensuring that there's an agenda and a prioritization for the resourcing and scale up of hepatitis screening, vaccination, and treatment services in South Africa. Next slide. So this just gives you an oversight of our harm reduction program in South Africa as managed by NACOSA and funded by Global Fund. And yes, they are core health services, and part of the health services is to identify risks as well as to screen for diseases. And so we provide within this program as well a layered services of opiate substitution therapy, so methadone for those that are injecting or smoking heroin. And we've had a great uptake in this throughout the program with the resources that are available to us. To mention that there are really, OST programs, managed in South Africa by government itself. It's usually run and supported by NGOs. I think there is one particular site that I'm aware of that, is funded by the city of Tshwane in South Africa that provides it through government resourcing opiate substitution therapy. And yet we have, reached over 30,000 people who inject drugs that are in need of this type of services and treatment. So if if we looked at previously the number that was screened for hepatitis B and C, there was a large number we had a 45% positive in the previous study with a 21% HIV co-infection across those main cities in the previous one. So if we looked, you may go ahead, it's fine, the next slide is in order. So let's just talk about the integration of our program. So having worked both on the ground and as well as in terms of management, we've realized that, in terms of treatment availability and uptake of treatment from those vulnerable and key populations, there are many, barriers to that. And one of those being, access to facilities or stigma from facilities actually forcing them to leave without actually accessing the services. So with the PWID programs that is managed by NACOSA, already now since 2019 providing opiate substitution therapy, we found in the previous grant period, which was in 2021 up until March 2022, an opportunity to work around piloting a hepatitis screening, testing, vaccination, and treatment service within 3 cities that we had done it with. So knowing that there are limitations in this, we decided to integrate this within our opiate substitution therapy program, knowing as well that it is higher that someone would adhere to treatment and complete treatment if they also had the stability of OST or methadone as well in their program. It was a small cohort that was, reached as part of that hepatitis pilot. And what we did is, as part of the OST program eligibility criteria, is also to do screening for hepatitis B and hepatitis C, and then refer accordingly either for hepatitis B treatment, through facilities, or hepatitis C within the OST clinics that were currently piloting hepatitis. You may move forward to the next slide. So this gives you a bit of an indication of what was done in the pilot. So hepatitis B was offered, and C screening and treatment was offered in City of Cape Town, City of Johannesburg, Sedibeng, and eThekwini. And in this, infographic that you have in front of you, you will see that 420 patients were screened for hepatitis B, C, and HIV. And 80 females were tested and 340 males were tested. The HIV prevalence amongst the group was 30%, which is not necessarily uncommon. We have an incredibly high HIV prevalence amongst injectors in South Africa. And then also we found a 5% hepatitis B prevalence and an 83% hepatitis C prevalence. The co-infection between HIV and hepatitis was very high, specifically in City of Johannesburg, which is well known as well for engagement in sex work. And that was at 37%. And those in Sedibeng as well, 100% that were screened and tested were found to be positive for hepatitis C and HIV. So 47 patients were placed on treatment during the pilot up to now, and 304 had received their first, of their hepatitis B vaccines. I want to highlight the successes, and the highlight of the success is really partnership. When you have partnerships with, interested parties as well as technical experts such as Groote Liver Clinic, this really enabled us to look at the access to DAAs that is needed for the treatment of hepatitis C and helped us coordinate that access. Also, we found, really good data on hepatitis C prevalence across our OST, a first time in fact. And then also, in terms of treatment uptake, there was good treatment uptake of 89%, initiated on DAAs, and 50% of them having been successfully completed. We do need to note as well that, when someone drops off from OST, this obviously impacts whether they would complete their hepatitis C treatment. And don't forget the structural barriers that include, social environment issues such as homelessness and family disharmony that could impact someone completing hepatitis C treatment. And then once again, access to NHLS is also a problem with that and having to go to private. If you could just move up quickly so I can quickly refer to the challenges. I think you've exited, but that's fine. So I just want to quickly refer to some of the challenges that just gives us an indication again so you can move down, is that, the DAAs in South Africa have now been registered and are incredibly expensive. In fact, the number that I require for treatment of my cohort is not manageable by my budget by any means. And so what we need to look at is, once again, rallying from government and Department of Health that, DAAs needs to be on the essential medicine list of South Africa, and that NGOs such as NACOSA and our partners need to be considered to be eligible for public sector pricing or below the single exit price that is expected in terms of this product. And then there's other things that we can talk about, but ideally what we're saying is we need to look at where government stands on this and how they're going to be resourcing and uptaking and supporting these hepatitis programs, because the situation is quite dire. And this is a curable disease, hepatitis C. We don't have to have people dying. If we have people coming together, such as NGOs, government, and international technical leads, guiding and supporting hepatitis programs and opioid substitution programs in South Africa. Thank you so much, Colleen.
Thank you so much, Yolaan. We appreciate that. And also, one interesting thing about South Africa is they actually have one of the very few programs where in the city of Tshwane, where harm reduction is actually funded by the city of Tshwane. So if international donor funding left, that would be probably one of the only programs that would still be running. So that kind of model is also quite interesting. Our next speaker is Dr. Maia Butsashvili, who is an infectious diseases physician and director of the Georgian NGO Health Research Union. She is also a member of the National Hepatitis C Committee and leads the process of hepatitis C treatment integration in harm reduction services. Thank you so much, Dr. Maia.
Thank you for inviting. So as I was introduced, I will be talking about process of integration of HCV treatment with harm reduction services. Next slide. So recent IBSS size estimation showed that we have 1.5% prevalence of people who inject drugs in general population, so it makes about 50,000 active drug users in the country. So we have NSP programs in 11 cities and 9 mobile units. So some harm reduction centers have available HCV viremia testing, and all of them screen on HPV and HCV. OST program coverage is quite good. We have 22 sites of OST programs, and 6 harm reduction sites provide HCV treatment. Next one. So hepatitis C elimination program started in 2015 in Georgia with technical support of US CDC and 3 antiviral drugs from Gilead. So we have very impressive changes of HCV viremia prevalence. As we see, SERA survey in 2015 showed 5.4% HCV RNA prevalence. This is about general population. And in recent survey, it dropped to 1.8%. Next. Next slide, please. Yeah. So we have problem with reaching thousands of people now. So people who are highly motivated already were enrolled in the program, and now coverage is getting low and lower, particularly among people who inject drugs. And so here we see prevalence among drug users. HCV prevalence is about 60%. We have very low HIV prevalence among drug users. So HBV vaccination coverage is extremely low. Again, IBSS survey results shows that only 7.5% of active drug users reported to be vaccinated. And we have high reinfection rate, which is about 13%. Next slide. So in 2017, the decision was made to integrate hepatitis C treatment in harm reduction centers. And For this purpose, we simplified the algorithm of treatment diagnostics and monitoring tests because the program considers quite a big list of HCV treatment monitoring tests, but for integrated treatment, we simplified this algorithm and we have very few tests during the treatment and pre-treatment. So it works like this. So if the patient has high FIB-4 score or high fibrosis stage F3 or F4, they are referred to specialized clinics. If not, they are staying at harm reduction centers, and physicians there, which is family doctor by profession, is treating these patients on site at harm reduction sites. But as I said, people with advanced liver fibrosis are referred to specialized clinics. It makes around 1/3 of people who need referral. So there was a study done about patient satisfaction and provider satisfaction, and clients as well as providers seem very happy with this integration process. So satisfaction rate was very high. Our problem is that regulatory requirements from Ministry of Health makes it very hard to expand treatment sites to the new ones. Next slide. Okay, so we have another problem which we have is that OST treatment sites don't have yet integrated HCV treatment clinics. We only have it in NSP sites. All this is related with very challenging and complicated regulatory requirements from Ministry of Health, because they consider them as clinics. So they require all requirements as of regular clinics. So we're trying to do our best to make it different to the regulation and make them explain that these are not clinics and they can just provide medications without having all features of the clinic, but this bureaucracy is not helpful at all. Another barrier is that vaccination rooms also need a lot of regulations, and we cannot vaccinate drug users on site at harm reduction sites. This is another challenge. So, and also we need more mobile units for NSP and OST sites, which would also provide HCV medications. Next. So the new projects we just started, pilot projects to improve coverage among PWID, coverage of HCV treatment and HPV vaccination coverage, is incentivization. So we do incentivization of PWID for making them enrolled in the treatment process and in HPV vaccination. So we incentivize the patients themselves and people who bring them. So it's kind of peer intervention. So we'll know more about outcomes, but it seems to be successful. So incentive seems to be working on hard to reach proportion of the population. So we will know more end of year, and we will share the outcomes. And then we plan to introduce these findings to state programs so that incentivization becomes a regular approach to improve the coverage of HCV treatment and HPV vaccination coverage. That was all very briefly. Thank you for your attention.
Thank you so much, Dr. Maia. We really appreciate you giving us an overview. And I think with Georgia, it is one of the successful programs where we see that integrated service, but we also see really a strong political will from government to be able to do this. So thank you. Our next speaker is Dr. Nhan, who is a medical doctor. She received her MD from Hanoi Medical University and has a PhD in public health from the National Institute of Hygiene and Epidemiology. Dr. Nhan started her work at the National AIDS Standing Bureaus in the Ministry of Health in Vietnam, and currently serves as head of treatment HIV in the Vietnam administration of HIV control. Please welcome Dr. Nhan. Thank you.
Thank you so much. So hi everyone. So Today, I would like to very happy to share with you about the Vietnam experience related to providing HCV diagnostic and treatment among the PWIT Islam now. So before we go to the our experience, I would like to give some information related to HIV epidemic in Vietnam. Up to now, we estimate that in total in my countries there are over 250,000 people living with HIV/AIDS. And in last year, we estimated that over 11,000 people, I mean, the new HIV positive case. Regarding the HIV, hepatitis C, so the prevalence of HIV anti-HCV among the people living PWIT in the Vietnam are very high, from the 60% to 80%. And the prevalence of anti-HCV among the people living with is very high too. So we estimate about the 30% of the people living with in the Vietnam have hepatitis C. So up to now, we are scaling up the ARV treatment for all the people living with, and up to now, we have over 72,000 people on HIV. On ART treatment. And on the Vietnam, we also scaled up the harm reduction activity too for the PWIT too. Up to now, we started the methadone treatment of the over 10 years ago, and up to now we have over 52,000 PWIT on the MMT. I mean, now they are PWIT before, but now they are using the methadone treatment. The last from the 2021 with support from Global Fund, the Vietnam we provided the HCV treatment for the people living with HIV and also for the PWIT too. So regarding about the PWIT, we would like to share with you about our model related to the integration of the HCV diagnostic and also HCV treatment for the PWIT. And this slide talking about the model. We coordinate between the methadone facility where are providing the methadone service for the PWIT, and also with the HCV facility where providing the ARV treatment, and also for HCV diagnostic treatment and follow up after that. And for each facility for methadone, for example, for methadone, the doctor and the nurse and the healthcare staff in the methadone facility, they are providing the counseling on the HCV among PWIT and the high cure rate of the high cure rate of the HCV treatment, and also the requirement for the test for HCV. And after the MMT, the patient, they aware about they are risk to the HCV. They also did about the HCV, and we will refer all the patient with anti-HCV positive to the HIV facility, and in there, HIV facility, the doctor will provide the HCV diagnostic, and if positive, they will provide the DA treatment and follow up after that. With support from Global Fund, I'm sorry. With the support from the Global Fund in last year, we with the support from Global Fund, we also providing the in order to providing the integrated of the HCV treatment for the PWIT and also for people living with HIV. We did on the SOP very simple with the service sample type to coordinate between the MMT facility and also HCV facility. And in that, the provincial CDC they play the key role to directing implementation and demand generation activity and the guiding service delivery and coordinating the resources, and also identify and address any problem that occurs during problem in the program implementation. And we also to more the mobilize support from the partner, WHO, and also all the participating from the CBO together. Actually, we do the many activity on the live stream, with CBO and with the attention participating from the clinical expert to communicate on the benefit of HCV treatment. And also we also estimate on the quick response team hosted by the VAC that uses a low messaging platform and to collect the service provider and throughout my countries. We try to mobilize the clinical expert on HCV treatment at hospital and international and also social health insurance expert. This point would like to clarify with you that up to now the Vietnam, the health insurance, they are the cover they are paid for the treatment for HCV treatment. Therefore, in order to boost to make sure about this accessibility, we also more organize to more the mobilization attention and participants from the social health insurance expert in delivering HCV treatment and also support from who social health students to reimbursement for service use. We also because in order to the mobile and in to more agree to diagnostic also treatment for PIWID, we have to do analysis and to provide the readout for HCV cure rate and providing disseminate this information to all the client, including the PIWID who are on the MMT in the MMT cell facilities. And here is the readout with the support from Global Fund 2 years ago, from 2021 and 2022, that we have over 16,000 people we have been received HCV treatment, and among them have about over 4,400 the patient on MMT, and you can see that the high cure rate of the HCV treatment among the people and among the people, I mean the people on MT very high, with 96.2%. And with this readout, the successful readout for support from Global Fund now, therefore now we are developing plan for HCV HPV prevention and treatment for high-risk group. And in terms of the PIWID, the own intervention will be focused on elimination of the HCV through the increasing awareness of among the policy makers, healthcare workers, and PIWID. We also focus about the importance of the viral hepatitis prevention testing and treatment. And also we are developing the intervention package for HCV prevention, including the reinfection treatment for the people with HIV for the KP. And we also continue to implement the primary prevention, including improved medical interaction and procedure, comprehensive prevention, including harm reduction and other evidence-based measures for the PIWID. We also to try to promote and simplify the model for including the decentralizing hepatitis C testing treatment in the district level, and with the cover by the health insurance. We also to allocating the increased financial resources for viral hepatitis C, including external locality funding and also the health insurance for prevention testing treatment. We try to diversify form for communication and demand generation to reach target population, combined with the provision of HCV prevention and treatment service. We also to work with the CBO and in order to strengthening the role of the community based on organization in reaching the target population, especially with the PIWID. We also to try to implement the policy advocacy activity to increase the social health for HCV treatment, and about some the experience related to integrated the HCV diagnostic and treatment for the period in the Vietnam. Thank you so much for the listening. Thank you.
Thank you so much, Dr. Nhan. And it's really interesting to see how Vietnam pulled the two together and were able to get more people who are living with HIV also diagnosed. Our next speaker is Nalinikanta Rajkumar, who is an activist who belongs to the community of people who use drugs and has lived with HIV for the past 20 years. Kanta is the president of the Community Network for Empowerment, CONE, a state-level network of 11 community-based organizations of people who use drugs, working to promote and protect health and human rights of people who use drugs since 2003. Kanta, we have had so many technical issues trying to get Kanta onto the call, but we are so happy that he is able to join us. So Kanta, can you please turn on your camera and your microphone, and we are ready for you.
Okay, thank you so much, moderator. Thank you, Chai, for inviting me. It's my privilege and honor to be a part of this webinar. Next slide, please. To give you a background about our organization, CONE stands for Community Network for Empowerment, which is a state-level network of 11 community-based organizations of people who use drugs based in Manipur, India, and it was established in 2011. Since 2014, we have been working on Hep C with a range of activity from awareness to providing free diagnosis and treatment, working with the government and developing different models, including in prisons. We have also been involved in the state and the national level advocacy activity to improve and avail quality HCV services. When we were working on all this, government of India had also started implementation of national program in 2019. Testing and treatment are available free of cost through this national program. However, uptake of hepatitis C care is very poor due to various factors. So we developed this model of same-day test and treat of hepatitis C among people who inject drug as a replicable model. Next slide, please. Going on to how we have done in terms of the method that we are involved, we work with the drug treatment center targeting drug users who are undergoing drug treatment in the rehab center. We provide on-site rapid diagnostic tests for hepatitis C RNA tests. People who are negative are counseled on prevention of hepatitis C. Next, please. The blood sample for those participants who were tested antibody positive are collected and transported to local diagnostic center called Babina Diagnostic, where hepatitis C RNA tests are done using 2net mol bio. Next, please. Those participants who were RNA positive confirmed were initiated treatment on the same day with the advice. Next slide, please. Yes, so those participants who were tested RNA positive were initiated treatment on the same day with the advice from the doctor at the Jawaharlal Nehru Institute of Medical Science as per the guideline of the national program. So we provide support to the participant during the entire process till they have done their SVR test. So next. So here is the care cascade of the model that I'm presenting now. We have screened 523 people, of which 49.5 were tested antibody positive. 100% of them undertook RNA test on the same day, out of which 64.5% of them were found to be viremic. So out of these 167 people, 99.4% were initiated treatment on the same day. 95.8% have conducted their SVR test, of which 89% of them have achieved SVR, and now they are cured from hepatitis C. Next slide, please. So in terms of the time that we are involved during the process, starting from screening till the initiation of treatment, the median time that was taken was around 6 hours 49 minutes, with the minimum time recorded as 4 hours 36 minutes and maximum time recorded as 12 hours 18 minutes. here I would like to note that we can decrease this minimum and maximum time to at least another 50%. This time the median time was a little longer because we use only one PrEP extractor. If we utilize two PrEP extractor of the mole bio machine, then we can reduce the median time to at least another 50%. So there was a limitation in terms of the availability of infrastructure that made the median time little longer. Next. So now the remaining two slides is on hepatitis B, where I am going to talk about the finding of the study that we have conducted to understand the efficacy of hepatitis of the rapid regimen schedule of hepatitis B vaccination, that is 0, 7, and 21 days. Next, so to give you a background on the genesis of one hepatitis B vaccination initiative among PV. Way back in 2012, WHO recommended rapid regimen schedule of 0, 7, and 21 days for hepatitis B vaccination among PV. However, the national program in India do not follow this schedule among the PV. Rather, they are following 0, 1, and 6 month schedule. So, for a hard to reach population like PV, this one compliance rate on 0, 1, 6 months is a big challenge. On the other side, when we look into the hepatitis B vaccination history among the PV community, most of them are not vaccinated. Our study shows 88% PV susceptible to hepatitis B virus. Therefore, during a period of October 2017 to July 22, one have vaccinated 677 PV following the rapid regimen schedule of 0, 7, and 21 days among PV. Next, last slide, please. So here is the intermediate results of the study which I am presenting now. The total number of PV in the cohort is 677. 100% of these people in the cohort complying on the vaccine schedule. The total number of blood sample that we have collected for anti-HBs test is 375. Now, till now, we have received the report of 192 patients, and we found 88% of them, their titer level at the protective level at only 23. That is 12% of them were found their titer level less than 10. We will be providing one booster dose to this group of people and we'll check their titer level again. The best part of this study is that the data we are generating can be used to advocate our government to recommend rapid regimen schedule of 0, 7, and 21 days for at least PV community under the national program. Thank you so much. I will be happy if you have any answers.
Oh, Kanta, thank you so much. I think this has been an extraordinary presentation because the results are incredible. To have 99.4% of those tested starting treatment is amazing. But I think this is really a testament to what happens when you have NGOs, civil society, and community groups, people who use drugs, networks, working with government to collaborate to have a program that will actually reach people who use drugs. And I think this one shows that if you do not include community groups and people living with HIV and people who use drugs and sex workers and men who have sex with men and trans and gender diverse people, if they're not leading programs, we are not going to achieve the results that we can, obviously, with this. So that the power of that community response is just incredible. Thank you so much for that. So thank you all to our speakers in this session. As you can see, we are running over time. However, Dr. Ganiyu Gamiyu from Nigeria is here with us. He's actually getting ready to get on a plane to go to another really important meeting. So we're going to ask him to please join us now and just give a little overview. He's not able to join the other speakers in the roundtable version part of session 3, but we're just like to call upon him now and ask him to talk about some of the plans for Nigeria, that Nigeria has for integrating viral hepatitis and harm reduction. Thank you so much, Ganiyu, for joining us. Over to you.
Okay, thank you very much for giving me the opportunity to share Nigerian experience regarding viral hepatitis program, as well as our current effort at integrating viral hepatitis into harm reduction program. Just as part of my introduction, I would like to let us be informed that the National Viral Hepatitis Program actually was established in 2013, and it is currently domiciled with the HIV program. And when we started in 2013, one of the first key steps we did was to inaugurate the National Viral Hepatitis Technical Working Group as part of the establishing governance for viral hepatitis program Nigeria. Following that, we developed some policy documents, strategies plan, as well as training materials, hepatitis facility directory, that is to guide those people who need to assess treatment, and as well as develop a roadmap for the subnationals in Nigeria. Also, one of the key things we did that is has added an advantage to the program is the activation of focal persons in 36 states, including the federal capital. In Nigeria, we have 36 states and the federal capital, on which currently we now have focal persons in those subnational levels. As part of our service delivery, the Nigerian government, through one of the subnational, that is national state government, has been able to screen about 190,000 people for HCV, and currently has also initiated about 2,800 of those who are actually infected with HCV. And one of the greatest achievements in national state through the federal government was the establishment. It was a declaration in 2020 to show that strong commitment for eliminating HCV in that state. And there's been a lot of work done in that state at the moment. And CHAI has also facilitated market shaping for HCV diagnostic to actually improve access to affordable diagnostic services in some health facility. At the moment, HCV RNA can be accessed at the cost of $25, where directly active antivirals can be gotten at the rate of $20 per month. And that has been the great effort of CHAI to ensure that. Also, we now have other key players like the Yakubu Gao Foundation, who is an NGO that has also supported one of the subnational, that is Taraba State, in the provision of affordable diagnosis and treatment for HCV patients in one of the local government. Also, Adamawa State also did remarkably well in assessing the Save a Million Life through World Bank grant to actually provide diagnostic and treatment services for viral hepatitis in the states. As part of our integration efforts of integrating harm reduction to viral hepatitis, I wish to point out that the viral hepatitis is one of the member of the technical working group for harm reduction, and vice versa. The chair for harm reduction is also one of the member of the technical working group for viral hepatitis. So it is actually integration ab initio, and that has actually helped in our integration effort in Nigeria. As part of some of the achievement, we'll be able to establish the National Drug Demand and Harm Reduction Program, which was established in 2019. Also, we've been able to develop national strategies and incorporate into the National Drug Master Plan. And also, we now have a guideline. We all developed this together, National Ghana on Needle and Syringe Program, which was actually developed in 2020. And at the moment, we'll be able to develop a training manual for viral hepatitis and HIV, which is currently being rolled out in custodian centers in Nigeria and among the key population. So far, we've been able to train up to about 100 health workers providing services in Nigerian prisons and providing services for key population in Nigeria. Another great effort was a pilot project that was conducted in 2021, which actually revealed that hepatitis B and C screening and referral services have been actually integrated as part of package for persons who inject drugs. And as I've said, the viral hepatitis focal person is a member of the Harm Reduction Technical Working Group. Also, during this process, we'll be able to identify the fact that there still exists gaps in assessing hepatitis and hepatitis C testing among key population. And as a rider to that, we recently conducted a national harm reduction assessment for key population. It happened in June this year, and we'll be able to identify a lot of gaps. One of the preliminary results indicated that that limited but ongoing screening for hepatitis B and C still exists among the key population, whereas diagnosis and treatment is still out of pocket, which is a real concern. However, effort is being made to ensure that these people are referred. Unfortunately, some of these individuals may not be able to afford treatment and diagnosis. Some of our key challenges regarding integration of viral hepatitis and harm reduction, and also as a program, is the fact that there is still low level of awareness about viral hepatitis among the general population, including the key population. And also there is inadequate program funding at national and at subnationals, and there is limited access to viral hepatitis services due to high cost of services. And also, as I've said, out-of-pocket expenses still persist in Nigeria, which is a real concern. If not for that, at least at the moment, we have beautiful structures ranging from at the programmatic level up to data generating infrastructure. They are all available at the moment, but the challenge is still the problem of out-of-pocket expenditure for viral hepatitis program. Also, inadequate capacity of health workers to manage viral hepatitis, most especially at the primary and secondary level. However, with the current integration of viral hepatitis and HIV, so as to get funds to be able to effectively and efficiently utilize limited resources, we'll be able to achieve some remarkable progress with the training of health workers that will provide same services at OSS for key population, also in the custodian centers. And also, there is issue of suboptimal data reporting, monitoring, and evaluation. Effort is ongoing. We just concluded a 6-zonal training on this issue. We hope that in the next 6 months, we are going to start recording results. And finally, the technical mechanism necessary for viral hepatitis implementation in Nigeria will require the following: advocacy at international and domestic level, so subsidize or for free screening, diagnosis, and treatment for viral hepatitis B and C for both the general and key population. Need to advocate for annual budgetary allocation and release to facilities is also a very important activity that need to be supported. Also, they need to explore alternative sustainable financing mechanism for subsidized or free treatment for viral hepatitis B and C. And we can leverage on some of the funding that is available. We have what's called the Basic Health Care Provision Fund, which is one of the funds being generated from the annual revenue generated in the country. Also, in the issue of insurance, we think it is high time the repackage of harm reduction, which may include HIV, hepatitis, need to be integrated into our insurance systems. And also, they need to also look outwards on how we can get support from donor agencies and partners. Also, integration of viral hepatitis services into other disease areas like HIV, which is currently being ongoing, and we hope to cascade it to either TB program and other relevant program. And finally, they need to scale up best practices from the achievement made so far in Nasarawa, Adamawa, and Taraba states to expand viral hepatitis services to other states. Thank you very much for listening. Thank you.
Thank you so much, Ganiyu. We really appreciate it. And I think you've highlighted really one issue that we all can work on in terms of advocacy at global, regional, and national levels. And that's trying to find different mechanisms for financing. One of which would be to include in universal health coverage HIV, hepatitis B and C, and have no out-of-pocket costs, because out-of-pocket costs when we're thinking of essential medicines like this doesn't make sense anymore. And I think that's absolutely right, where we can also start looking at innovative financing mechanisms for bringing together the different people in our countries. You know, we also need to start looking at our domestic budgets. Where's the money going? Is it going to the war on drugs? And is it all about punitive approaches when it could actually go to health and justice and communities, for example? So it would be, and as Suchitra, my colleague, has actually just put into the chat a link about a webinar we're having next week, where we will be talking about how we can look at funding, domestic funding, international funding that's going into the wrong things, and how it can actually go into the right things. So our next panel, and people, I know we are running late. It's my fault, because everyone has been, the presentations have been so interesting. It's been a challenge to cut anyone off. But for this last session, I would like to call Dr. Nanda Myo from Myanmar, who is a consultant psychiatrist at the Mental Health Hospital in Yangon, as well as the project manager of the methadone maintenance therapy program at the Ministry of Health in Myanmar. Dr. Maria Helena Simbin, who is a clinical psychologist in counseling, and has been working at the Department of Mental Health in the Ministry of Health in Mozambique since 2013. Dr. Jebet Boit, who is an epidemiologist and the Deputy Director for Medical Services, as well as the Program Manager for Key and Vulnerable Populations in Kenya. And last but not least, Dr. Zinkoko Lin, Medical Doctor and Project Manager with UNODC, the Regional Office for Southeast Asia and the Pacific. So thank you all for joining us. I'm really great to see you all and have you here. And one of the reasons we wanted to specifically talk to all of you is because you are some of those 12 countries that have asked Global Fund for help on hepatitis. And, you know, we want to be able to talk to you a little bit about how you're actually thinking about doing that. So I might just start with Dr. Nanda, if you don't mind, and ask you about Myanmar's plans to further integrate, because you have done some of this in the past as well.
Thank you, Colleen. Good afternoon, good morning from the different parts of the world. I'm Nanda, greeting from Myanmar. First of all, I would like to say thank you very much for giving me this opportunity to be part of the panel to discuss about the harm reduction services in Myanmar and how to integrate the viral hepatitis treatment for the key population, the people who inject drugs. And thanks to Harm Reduction International and Chai for giving me this opportunity. So currently, we have a screening services for all the people who inject drugs, who are coming to the harm reduction services and also to the methadone clinics. So we screen all the clients, HIV, hepatitis B and C also. And recently, National ARDS program, they launched their hepatitis C treatment and HIV and hepatitis C co-infections. So National AIDS program plan to treat 4,300 clients this year, and the next year they're scaling up to 10,000 co-infections. And then this is a part of the, I think, global fund funded. And then we have a National Hepatitis Control Program. National Hepatitis Control Program have developed a national simplified treatment guideline for the hepatitis C. And then there are 7 designated general hospital. At that hospital, we can get the hepatitis C treatment. So this is currently we are doing. But at this point, I would like to say say we need to integrate that plan for the viral hepatitis and the harm reduction. So we will see a lot of, we have discussed, indeed, we need the physically the vulnerability of this illness is on the same population. So as you all know, the prevalence of the hepatitis B and hepatitis C are higher among the people who inject drug. And then these people are in the drug treatment center, methadone clinic. So please allow me share a little bit about the drug treatment situation in Myanmar. So our drug treatment program have right now 89 methadone clinic, and recently we add one, so 90 methadone clinic. And at that, the whole country, there are more than 25,000 of patients are retained in the methadone maintenance therapy. And all the new methadone clients have a screen for both hepatitis B and C, and also the HIV. For HIV, it's okay. So we have some methadone clinic is a one-stop service, so they can get the ARD on that methadone clinic. But for the hepatitis C, we need to refer. If the screen positive, we need to refer for the further management like diagnosis and other treatments. So we need to refer it. So when we look back to the 2022 data, so among new methadone clients, the positivity rate of the hepatitis B is like 7%, but for the hepatitis C is 37%. This is among the new methadone clients. So, for instance, like in our hospital, Yangon Mental Health Hospital, we have 700 methadone clients. So, like the exact number is 296 have hepatitis C positive. So we at that time we have a lot of challenges to refer to the other facility. So we only have a screening service, and then we have a refer for the diagnosis and other further management, that kinds of things. So right now, to compare with the previous year, but right now it's a little better, and more and more patients get the hepatitis C treatment. And then we provide the hepatitis B vaccination with a rapid scheduling if they are hepatitis B negative. And this is we are doing this this one. So when we refer to the other facility for the diagnosis or that kind of thing, this is not happening all the not close to the methadone clinic. This is the case for the the urban, the big city settings. So most of the clinic and most of our clients in the remote or the far away area. So how to link and how to the hub and the satellite. This is we need that kind of program magic or that kind of geographical technical support for that. And then we need then more and more the diagnostic facility which is close to the methadone clinic, or maybe the in one side, that kind of thing. So we have tested so every year, and then we retest it, and but we just the record who are negative and positive, that kind of thing, and then just refer it. But we can't provide that. We know that there is a cure medicine cure facility, but still there's just the hepatitis C treatment gap is really huge for the people who inject drug, especially even they are retained in the methadone maintenance therapy. So this is a brief. I want to say what we are currently doing. So,
No, thank you so much. And I think one of the issues you've raised there is that co-location of services, right? And being able to actually reach the people where they are as well. And that's why I think that example that Kanta was talking about earlier from the Cone example of actually having communities working with government to be able to do service delivery is going to be essential. But I do agree that some of these challenges, especially around the technical assistance that's now needed, is something that we have to start documenting and bringing to a broader audience. I want to come to Dr. Simbine next and have have you talk a little bit about where you think are some of the current challenges and obstacles to implementation for this sort of integrated service delivery implementation. Dr. Simbine, are you there? Nope. Okay, Dr. Jabet, can I come to you instead? Great.
Yes.
So in Kenya, you've also been doing this, and it's been a program that has long been a priority for the government of Kenya. And so I think from your perspective, it would be interesting for us to learn a little bit more about your plans to integrate community and civil society into service delivery as you move forward to further integrate.
Yeah, thank you very much. So for Kenya, let me just give a bit of a background. We began harm reduction way back in 2009. So the journey has been step by step, but we have been able to appreciate the advantage of integrating community and the civil society. So what we have done so far and what we plan to do is number one, as a country, viral hepatitis programming is integrated, first of all, within the national HIV program. So that was an initial win from the get-go. And then when harm reduction programming began at around 2009, and we began medical assisted therapy clinics, we adopted the comprehensive service delivery, what we call one-stop shop. So therefore, we provide hepatitis screening, vaccination of hepatitis B, and also, screening, diagnosis, and treatment for viral hepatitis C. So that is what I think policy has really helped us from the get-go to integrate these services. But now when we speak more concerning integration or concerning community and civil society, when we began intentional screening, diagnosis, and treatment, especially for viral hepatitis C, the approach we used is that we're well aware not all our injecting drug users are within the medical assisted therapy clinics or OST clinics. So what we did is seek out the civil society organizations where we have drop-in centers, that those who are still in active drug use have not opted into medical assisted therapy yet or are not ready for MAT. So when we're distributing our commodities for screening and testing, we include them. And we're able to liaise to make sure that, some of them still access services within the drop-in centers and they still come for medical assisted therapy. So we know we have those gray areas or intersection, but just being able to work very closely with the leadership within the civil society to ensure that we're able to screen as many as we can, and most importantly, treatment. So we don't treat the drug users who only access, services within the medical assisted therapy clinics. But what we do is ensure that even the drugs for those who screen positive are distributed to those who in civil society service delivery centers and those also in the MAT clinics. Most importantly, a success of integration is using peer-led strategies. So that means that as much as we have trained the clinicians, we have had joint meetings and so on and so forth, we recognize the role of the peer educators and outreach workers, because we need these clients to take their medicines every day for 3 months. We need them to do proper follow-up. And therefore, that means that we sensitize the peer educators. They know their colleagues who need to go on medication. And therefore, if anyone misses their medication within the service operation hours, then they would immediately embark on defaulter tracing. So that helped us to have very good retention rates to treatment. And we achieved cure rate of 98.4% for the first round of
the cohort that received hepatitis C treatment. So those are some of the small steps, that we've been able to take, and we've seen it works best, being integrated, and then of course involving the community. We've had studies that have been conducted. We engage the communities. We have story sharing when it comes to the success of treatment. For us to tie both ends is to just have the communities speak as advocates of the benefits of being treated. I know I can speak a lot more, but let me pause there for more if there's any other question. Thank you, and over to you.
Thank you so much. And you have highlighted, I think, such an important point, which is about outreach workers and peer educators and the need for them to be included in programs, not just included, but actually seen as a critical, essential partners in any program delivery. And I think also for governments to also realize that civil society, community-led groups, peer networks actually have an expertise that is just as relevant as a government expertise. And so, and one of the other things is for also our donors, when we're talking about technical assistance, is really to also ensure that our outreach workers and our peer educators are paid. Because we keep asking people to do work as volunteers or, community healthcare work volunteers and things like that. And this is not appropriate because in the North, we would never ask anybody to be a volunteer to do that kind of work. But donors expect us to do that in the South. And I think we need to start pushing back on that as well. Dr. Simbine, I come back to you. And really the question is about how is Mozambique looking to implement integrated services, but particularly how will you overcome some of those challenges and obstacles that you've identified?
Good afternoon, everybody. Thank you so much for the invitation. And we look forward and hoping that we can answer all the questions. But first of all, I have to say that for us, the hepatitis program is under the program for HIV and STIs control, but the harm reduction is under us, the mental health department. So we work as a one group on hepatitis and harm reduction. And so we start our program in 2018. This is the first time that we came with the harm reduction program. And we used to give the full package that WHO suggests, the 10 package that they suggest. Now we are implementing the PrEP because it's something new, and we think that there should be a very nice thing to add it. So now we have 11 packets, and not only 10. We used to give the needle and syringe. That was a beautiful program among the people who inject drugs. And we have the stakeholders work with us. Is the one who do the outreaching and follow these people that inject the drugs. We have installed centers. We have now 4 centers in kind of some parts of the country, like at the north, center, and south. So we have a centers in Mozambique, 4 centers who work full like they are the other arms that we have for harm reduction, because we know harm reduction is not only about the needle and syringe and OST. So they work, we work together. For the OST, we started also in 2019, and now we have, it's a pilot that we start here in Maputo, the main province. We have now around 260 something people who inject drugs on OST. And we call here APTU. For us, we call the APTU is the support program for people in opioid treatment. Is APTU. Most of them call APTU is a Portuguese word. So we have almost 267 people enrolled in OST, and this APTU works as one stop. So these people can have HIV treatment, hepatitis, ST, even for sexual educational, psychological social support as well, because we know that these people they are coming with some mental diseases. So we work as one. For the hepatitis, we at the first when we run and we start the program, we called it screening and test and treat those people. But unfortunately, I think most of the panelists talk about the funds, and we have the problem with the fund as well, unfortunately. And for the PWD, we are focused on hepatitis C. Now we have a program, a pilot running for hepatitis B, but it's focused on the pregnant woman, because we don't have the funds to do it, but we are willing to provide this. And with the global fund, we think we can manage, because now we are starting the grant making again, so maybe. And from those people, we are rolling at hepatitis treatment. We managed to treat almost 59 patients, and this 59 patients we could treat and go well, like a number of 33 patients. We have 17 patients waiting for the treatment. We have waiting for the treatment, and fortunately, we know that we could manage to buy some tests, so we can screen and begin the treatment as well. So this is mostly what come with us. Among the spirits, the harm reduction program, we managed to develop guidelines even for hepatitis, for guidelines for key population as well. We managed to develop guidelines in all the SOPs regarding to harm reduction. We're talking about the OT, needle and syringe program. We talk about the management of overdose. We use Naloxone. Our OST is with methadone, because for us it's more affordable to get the methadone besides the buprenorphine. Our challenge, regarding to our challenge, I think it's not that different. We said we need to advocate more so we can expand the program. We're willing to expand for four sites around the country, but we are willing to expand because we know the population of PW it's enormous. It's enormous, and with this program in our capital, Maputo, we have we think almost 2,000 people waiting and willing to engage the OST treatment. So that shows how much that our program is efficient and be doing a really good thing. But we still need to advocate, because unfortunately we've been cut the needle and syringe program because of the politicians and all those things. There is misunderstanding of giving needle and syringe, because there's misconception that we are giving them drugs or intended to them for use drugs. So we need more advocacy on that. We still need more advocacy for even for the insumes that we consumption of needle and syringe, the methadone. We are still popping the methadone with the syringe so we can make the hormones. So we need that, all those things that can make a good program running. We are running with some
challenges, resources.
Yes, some challenge, and so we need that. Advocacy for the more budget for the hepatitis, because now hepatitis only focus for PYWD, but it's important to think about the hepatitis B, the vaccination and all that.
Sorry, Dr. Simbine, I'm just going to ask you to stop there because I would like to get to Dr. Zinkoko, and we're already really way over time. So I thank you all for your indulgence in letting us move on. But thank you very much. And it is, I mean, I think it's important for us to also think about what happens when NSP gets cut and what will be the impact on hepatitis, viral hepatitis. Dr. Zinkoko, thank you so much for being here today. We really appreciate it, and for getting your perspective, because you're working with UN and ODC in Indonesia, and so it would be good for us to understand what kind of help that you've been providing, or assistance that you've been providing the country in terms of moving integrated services. Thank you.
Thanks so much, Colleen, for the question. And hi, everyone. Actually, I'm based in Bangkok. I work on the regional portfolio, but we have a whole team of colleagues working on the whole range of drugs and health issues, like prevention of substance use, treatment of drug use disorder, harm reduction, and as well as access to controlled medicines. So we have a whole team there. So what we've been doing in Indonesia right now is like, based on the UN Division of Labor, we are more on the prevention side in terms of when it comes to hepatitis, viral hepatitis diseases, because we promote evidence-based harm reduction, intervention, and strategies in countries. And also, we also try to strengthen the linkages to services like other speakers were mentioning, one-stop shop services or things like that. And what we promote here in the region is the voluntary community-based services for people who use drugs. And so one of the principles is the no wrongdoer approach. So whatever the health and psychosocial support that a person needs, they should get that kind of services. So that's what we promote in the region. So what we also see in the region is that we know that the HIV and hepatitis C co-infection rates are really high in this region. Like 9 out of 10 people who inject drugs who have HIV also have like hepatitis C. And then what we see in the region now is the increase in the use of stimulant drugs. So all the country except Myanmar and Vietnam reported that the main drugs of concern, or the main drugs of treatment admissions in the region for stimulant use. So we know that stimulant use also, whether injected or not, stimulant drugs are also associated with increased risk of hepatitis, viral hepatitis diseases, and HIV. So it is one of the areas that we've been trying to engage with stakeholders in addressing the issue. So we've been trying to promote the availability and access to harm reduction services for stimulant users as well. So that's one of the areas that we've been focusing on, and also we focused a lot on policy advice, advocacy, coordination, because drug issues span a lot of like areas and sectors in the government, for example, drug control agencies, Ministry of Health, and civil society groups as well. So we support a lot of coordination work as well to promote the enabling environments where people can have access to treatment and care services freely and voluntarily. So that is pretty much of it. I don't know if you would like to have any follow-up questions.
I have a bajillion questions, but I can't ask any of them because I've got everyone telling me that we've run completely over time. But thank you so much for that. And I think that's the other thing is like, how are we actually utilizing some of these multilateral organizations to be able to come together and help us implement these one-stop shops, if you like. And particularly since WHO has also made these recommendations. So thank you so much for that. Now, I've been told I have to stop this webinar, but I just want to bring on our last speaker, who is Aditya Teslim. Aditya was going to open our webinar, but we've had so many different technical issues today. So he said he was very willing to close the webinar today. So Aditya is the advocacy officer with the International Network of People Who Use Drugs. He identifies as a person who used drugs and has lived with HIV for 20 years. He's been involved with harm reduction in Indonesia from 2005, where he actually used to have to hide needles and syringes and then distribute them on the streets while educating other fellow drug users to use drugs safely and try to avoid law enforcement. And now he is doing advocacy at national, regional, and global levels. And we're so excited to have him. And I cannot thank you enough for being willing to be here today. Over to you, Aditya.
Thanks so much, Colleen, and thank you so much for. I'm really sorry for the mixed up, and it's really been great hearing different experience and examples from different countries. As Colleen mentioned, my name is Aditya. I'm with the International Network of People Who Use Drugs. So I'm gonna start with a little story of myself about 20 years ago, back in 2004. I was diagnosed with hepatitis C, and soon later, the following year, I was tested positive for HIV. And I mean, similar to most of other people's experience, I was devastated. I was in denial. I was angry, and I had only one thought: to end my life. And however, between those turbulences of my life, there was one message that continued ringing so loudly in my head that the doctor who was looking after me said this: "Hey, I'm not too concerned with your HIV. Your CD4 count is high, and we can try to keep it as high and as long as we can. You'll be all right. However, it's not HIV that's gonna kill you. It's hepatitis C." At that time, there was very limited option on treatment, and it was also ridiculously expensive, and also with very small chance of success. Today, Hep C is curable, but why is it my story still experienced by most people who use drugs, and that people are still dying from a curable disease? And despite the availability of the new generation of medication like DAA, with high cure rate, good tolerability, low pill burden, less drug interactions, less side effects, there's still ongoing problems and barriers to this treatment and remain in many contexts, including cost, delay, stigma, and discrimination, lack of political will. Input conducted a values and preference study for people who use drugs and accessing HIV, hepatitis, and STI services. Despite there's a consensus and strong preference for this treatment, our community still faces delays for up to 3 months to get medication, including the endless list of pre-treatment blood tests, leading to many people withdrawing from accessing the services altogether. And in some contexts, it's only offered to people who use drugs who are HIV positive. In some countries, this treatment is simply not available, or even when it's available, drug use is used as an eligibility criteria, leaving out people who are still actively using drugs, including a case where people had to be off of methadone, forcing abstinence from drugs. And recently, I mean, there's much talk about enabling environment, peer-led responses, community-led responses, decrim, and elimination of stigma and discrimination. However, how such change will be realized when we are still yet to see a comprehensive access to well-accepted, cost-effective, evidence-based HIV and hepatitis C prevention and treatment intervention among people who use drugs? It's critical to have definition of what it's meant by behavioral intervention, especially in the context of people who use drugs. We need to invest in different models of service delivery. There's no one size fits all. Our studies show that peer navigators and drug user-led responses impact on initiation and retention, treatment, and prevention programs. And we also need to maximize the use of new technologies, including underutilized health technologies. Input is currently working with a consortium led by MDM under the Unitate grant to create a simplified testing care model for Hep C diagnosis and to reduce number of lost to follow-up. And to effectively integrate viral hepatitis and harm reduction services, we need to dismantle the structural barriers, including behavioral intervention that are aiming towards abstinence and also social control. Stigma, discrimination, and judgment are also among the most common barriers that people use drug face when accessing viral hepatitis and harm reduction services. Some people refer to being treated like a child, seen as irresponsible, and judged as not caring about their health, or cannot be trusted to adhere to the medication. Integration of viral hepatitis and harm reduction services will only be successful if primary focus is on ensuring genuine person-centered care approach. This means that the design, development, and delivery of all intervention and approaches should be driven by what works best for and it's most acceptable to people who use drugs. With that said, input's perspective, providing people-centered care is linked to peer-based and drug user-led approaches due to the critical role that peer workers plan on reaching people and supporting them to access services. Peer-led responses and community mobilizations are fundamental to ensuring that the design, development, and delivery of intervention align with community and individual needs and priorities. And realizing the right to health for people who use drugs will require not only the removal of harmful and punitive laws and policies and practices, but also the appropriate funding and scale up of drug user-led interventions and services that properly recognize the value of peer-led interventions. And until we properly value the expertise and values and preferences of people who use drugs, criminalization, stigma, and discrimination will continue to fundamentally erode the health, rights, and dignity of people who use drugs globally. Thank you so much, Colleen.
Thank you so much, Saditya. And I think you basically pulled together so many of the challenges, but also given opportunities for how we can better integrate programs and how we can actually reach people who use drugs. So thank you so much for that very, very powerful intervention. I want to say thank you very much to all of our speakers who are still here with us, for all of those who gave us the most amazing presentations today. My apologies for going over time, but I hope that what we can do is actually a follow-up to this, where we can have this work, in 6 months and in a year, when we can come back together and actually look at how we're further implementing what our goals are and how we can start to achieve some of what's been put into, for example, the funding requests, and how they actually made it through grant making. I think that's also important for us. And I think, also taking into account what Dr. Simbine said, where harm reduction is not just about needle and syringe programs and opioid agonist therapy and naloxone. It's about people, and it's about how we can actually address a variety of issues that people may have. So thank you all so very much. We will share the presentations and the video on our YouTube and on our website. And thank you all so much for staying with us, even though I went very much over time. My greatest, deepest gratitude to you all. Thank you very much. Have a great rest of your day. Aditya, you're awesome. Thank you so much. That was amazing.
I'm really sorry.
Oh, please, not at all. I'm just so
Because
happy.
the thing is, there are 2 hepatitis C webinars I'm speaking at. I thought it was tomorrow and Thursday.
Yeah.
I have both on calendars, and then I just realized that Tammy sent me an email. Are you having trouble in signing in? Oh, what trouble? Wait.
Well, we should stop recording, Tammy. No, it's amazing. Actually, I was going to ask if you don't mind